right, thank you. So a tough act to follow indeed, but I will try. So what other options do we have with novel agents? Well, first of all, it's certainly a very exciting time right now in CLL. We have an embarrassment of riches with all of these new agents, and really we've been talking about the future in CLL for a long time. The future is now with the drugs being approved and several new drugs getting close, so it's a very exciting time. So I'll just briefly review some of the other options that have been out there historically. You've heard about ofatumumab. You've heard about alemtuzumab, which is not completely gone. It's still available from the company, but it's not used very much. It has been a drug historically that's been very helpful at clearing out bone marrow and blood disease. It doesn't work as well in bulky lymph nodes. In contrast, we had high-dose steroids, methylprednisolone usually, which was very effective at shrinking lymph nodes, but wasn't as effective in the bone marrow. So pairing up these two drugs was very efficacious, but unfortunately also very toxic. Patients had major issues with infections, and so this was a lot of the impetus to develop the new drugs like the kinase inhibitors. I'll mention lenalidomide briefly. It's an immunomodulatory drug that you heard a lot about this morning in multiple myeloma, where it's really revolutionized that disease. It's been explored in CLL as well, and certainly has activity in CLL, as was seen in the earlier studies led at MD Anderson and Roswell Park, where they started out using doses similar to those used in multiple myeloma and saw a decent amount of activity in CLL, about a third to half of patients responding with a smattering of CRs here and there. But unfortunately, using these doses, there were very significant tumor flare reactions where patients shortly after starting on lenalidomide would actually have growth of lymph nodes that could be quite painful and was certainly very frightening to people. Tumorlysis syndrome was observed in these studies, and certainly in the relapsed refractory population, patients who have cytopenias at baseline, these were certainly enhanced by lenalidomide. I will highlight some of the later studies, such as a German study that started at a much lower dose of lenalidomide, 2.5 or 5 milligrams, and then slowly escalated up to higher doses, up to 20 milligrams. Using that scheme, the drug was a bit better tolerated in CLL, although we still see high rates of neutropenia and thrombocytopenia in this population. Infections, as we expect to see in these heavily pretreated CLL patients. The rates of tumor flare were less, although they were still there, close to 10% of patients, and they were able to avoid the Tumorlysis Syndrome. That was not seen with the dose escalation. But unfortunately, using this scheme, the overall efficacy on this study was quite low, with a response rate of only 12% and a median progression-free survival of just 6 months. If you did look at the patients who made it up to 20 milligrams, there was more efficacy seen there, but it certainly can be a problematic drug to administer in CLL. I think if we didn't have a lot of other options, people would be excited about lenalidomide in CLL because it does have activity. I think it may still have a role in CLL in combination with other agents, but I think given the toxicity profile of the other agents that we're going to talk about, I think it's not going to be developed as aggressively in CLL as it is in lymphomas and other diseases. So you heard briefly about the Gauguin study. I won't go over it too much, but just to highlight that this is an active antibody in CLL. Probably is more active as a single agent than rituximab based on these data and the data from CLL11. And I think in terms of future combination strategies, this is certainly a good antibody to consider combining with kinase inhibitors and BCL2 antagonists, for example. Probably not going to be used as much as a single agent. So I will say a word briefly about chimeric antigen receptor T cells. This is a very similar looking chart as you've seen before. I'll just go through it briefly for those of you who aren't familiar with this technology. The idea is that patients have T cells, not B cells like CLL cells, but T cells, leukapheresed. Antibody-coated beads are then used, and there's a variety of different transduction vectors that can be used. Usually lentivirus or other viruses are used to transduce a chimeric antigen receptor into the T cell. And this can recognize a variety of different epitopes. The one that's been utilized mostly so far has been CD19, which is fairly ubiquitously expressed on B cells. There is a sort of a parallel effort going on to look at another antigen called ROR1, which seems to be a bit more CLL specific, and so there's groups looking at that as well. These T cells are expanded, the beads are removed, and then the patients are given just gentle lymphodepleting chemotherapy, not like the conditioning regimens that would be used for a full-blown transplant, and then the T cells are infused. A lot of excitement certainly generated over the original patient that we saw in the New England Journal paper. The delayed tumor-lysis syndrome, as was mentioned, certainly needs to be monitored for very closely. We saw very nice clearance of the bone marrow and a marked reduction in lymphadenopathy in this extremely heavily pretreated patient. So a lot of enthusiasm. As you saw, the updated data from this last ASH meeting don't look quite as excellent. Certainly do see responders, including some complete responders. This is the updated data from the UPenn group looking at their CTL19. Some of these responses have been durable, 2 to 3 years. They see persistence of the T cells out that late, which is encouraging. but we also do observe this cytokine release syndrome, which can be quite intense and life-threatening. It does seem to be mediated by IL-6 in many patients, and so the tocilizumab antibody can head this off, but I think it certainly highlights the need for the expertise of the center and being familiar with this and being able to manage these patients who can get quite sick. So I'm going to spend the bulk of the rest of the talk focusing on ABT-199. You can see here where it sort of fits in a little bit within the overly simplified biology of a CLL cell. We've been talking mainly so far about the kinase inhibitors, which certainly target one of the Achilles heels of CLL pathophysiology, which is overactive B-cell receptor signaling. But I would argue that the other Achilles heel of CLL pathophysiology is the apoptotic pathway and BCL2, which is pretty uniformly expressed at very high levels in CLL cells relative to pro-apoptotic proteins. And its levels can be enhanced further by interaction with the stromal microenvironment, T cells, bone marrow stromal cells. All of these pathways, and even the B-cell receptor pathway, eventually feed into the apoptosis pathway and raise the apoptotic threshold and don't allow the CLL cells to die when challenged with chemotherapy or other agents. So rather than bothering with all this upstream stuff, why not go straight for the kill, the powerhouse of the cell, the mitochondria? And that's the idea behind ABT-199. I'll talk briefly about the mechanism of action because it's quite novel. This is not a kinase inhibitor. It doesn't inhibit an ATP binding pocket. It's not really an enzymatic inhibition. It's really a true antagonist, and it's a displacement phenomenon. So here you see a healthy mitochondria that has a balance of pro-apoptotic proteins such as BAX and BAC, which sit on the mitochondrial outer membrane. And you have anti-apoptotic proteins, which there's a variety of them in this family. You've probably heard of MCL1, BCL-XL, BCL2, et cetera. Really the one that seems to be the key in CLL pathophysiology is BCL2. It's expressed again at very high levels and certainly relative to other pro-apoptotic proteins. So what does BCL2 do normally? Well, it normally sequesters what's called BH3-only proteins. These are other pro-apoptotic proteins that get bound to BCL2, and when they're bound to it, they can't interact with the other pro-apoptotic proteins to cause cell death. And so this makes these cells highly resistant to chemotherapy, particularly when they've been through prior rounds of chemotherapy. And so the idea with ABT-199 is to disrupt this interaction. So ABT-199 binds more tightly to BCL2 than the other BH3-only proteins, and it thereby displaces the BH3-only proteins, which can then interact with BAX and BAC. And what that can do very rapidly is to punch a hole in the mitochondrial outer membrane, so-called MOMP, or mitochondrial outer membrane permeabilization. And what this does is it releases cytochrome C, and that activates caspases, which can destroy the cell through an apoptotic mechanism, and it does it quite rapidly. When we work with this drug in the laboratory, we see within 1 hour we see CLL cell death. And so this is a very potent drug, and this was observed when it came into the clinic. So as was alluded to, Tumorlysis Syndrome was an early problem with this drug. It's always challenging to pick a first-in-human dose, and the dose that was picked was 200 milligrams, which in retrospect proved to be far too high. You can see some of the data from the first 3 patients who were treated on the ABT-199 first-in-human study. In the red, you see the lymphocyte count rapidly depleting within even 8 hours of dosing. At the same time, these patients had rapid reduction in lymphadenopathy, but unfortunately, at the same time, they had LDH that was kind of going through the roof, and one patient up to 10,000 from normal within 24 hours. And so all 3 of these patients treated at a high dose of ABT-199 initially had laboratory tumor lysis syndrome. Fortunately, all of them did fine with medical management, and they went on to stay on study for several years, some of these patients, 2 to 3 years at least. So clearly that was too high of a dose. So the study was revised to start at a dose of 50 milligrams with stepwise escalation, intra-patient escalation. But nonetheless, even with this dosing method, there was a case of acute renal failure, and then there was the subsequent 2 deaths, one on the study with rituximab in combination, one with ABT-199 alone. And so as was mentioned, the study was put on hold in December of 2012. And I think to the credit of everyone involved with this, there was a very careful analysis done of which patients were experiencing TLS to try to get to the bottom of this. And these are some data that were presented at the EHA meeting last year, looking at the patients initially by various clinical subtypes, patients with bulky lymphadenopathy greater than 5 centimeters or not, creatinine clearance less than or equal to 76, elevated lymphocyte count or not. And then some PK analyses were done and some modeling that looked at the exposure of the drug at various doses. So I mentioned to you that 50 milligrams was chosen as the dose that was used for many of these patients going forward. But in the blue, that 50 milligrams actually gives exposures of the drugs well above that level in the patients who had tumor lysis syndrome. So even 50 milligrams actually is too high of a starting dose for this drug. In the salmon color here, there were some patients who were treated with a starting dose of 20 milligrams, and you can see that all of these patients stayed below this dangerous threshold of tumor lysis syndrome when starting at 20 milligrams. And by using this careful analysis, they were able to come up with this risk stratification scheme of low risk, medium risk, and high risk that were based on nodal mass and lymphocyte count. So it's a very simple thing that can be calculated. It doesn't require an online calculator. You can just look at it, look at the scans, look at the blood counts, and you can risk stratify the patients. And so that's what's been done moving forward. The starting dose thereafter was 20 milligrams. There was very slow weekly intrapatient dose escalation on all of the ABT-199 studies. And now I'm going to show you some of the data that incorporate that new dose escalation scheme. These are the latest data cuts that have been publicly presented. This is from the EHA meeting last year. So this is the first in human phase 1 study. See kind of typical CLL patients, median age of 66, a male predominance. Lymphocyte count on the low side for these patients in general. These are heavily pretreated patients who have often been through a lot of chemotherapy, and so they tended to have more bulky lymphadenopathy in over half of patients. They had high-risk features. 3/4 of the patients had unmutated IGHV. Close to a quarter of patients were deletion 17p, and nearly all patients had had fludarabine in the past, and most of them were refractory to it. So like the kinase inhibitors, once patients get through this initial risk of TLS, this drug is very well tolerated. So there is a bit of diarrhea seen as well. There's some neutropenia and some mild nausea. These are typically grade 1 or 2. In terms of grade 3, 4 events, neutropenia in about a third of patients. Some of this is from prior therapies, but some of this is probably from ABT-199 itself. BCL2 is actually important in neutrophil survival as well, and so that is an on-target effect of the drug. But nonetheless, the rate of febrile neutropenia was quite low, and these patients typically respond nicely to growth factor support. So why is it worth potentially enduring a risk of tumor-lysis syndrome? Well, here you can see some of the efficacy data from the first-in-human phase 1 study. And like with the kinase inhibitors, we see very deep nodal responses. The colors here all represent different maximum doses that patients reach. So at a variety of different dose levels, we see very deep nodal responses in about vast majority of patients. But what's very different from this drug, from the kinase inhibitors, is that we also see a marked reduction in the lymphocytosis in the blood, with nearly all patients getting close to 100% reduction. And perhaps even more strikingly, and in stark contrast to the kinase inhibitors, we see marrow clearance with this drug. This is not chemotherapy. This is an oral novel agent that's very easy to take once patients are on their stable dose. And here at median time of about 5.5 months, 90% of patients have had at least a 50% reduction. But I think even more impressively is all these patients here who had 100% reduction, marrow clearance, in many patients taking this single agent in very heavily pretreated population. And a minimal residual disease analysis has been performed kind of ad hoc on these patients. This was not built into the original protocol, so take this with a grain of salt. But nonetheless, there was no detectable MRD in 6 of the 11 patients who were measured. There was some low-level MRD in some of the other patients, but even achieving MRD negativity with a single novel agent, I think, is very striking. So aggregating the overall responses in this phase 1 first-in-human study, close to 80% of patients achieved a response. Like the kinase inhibitors, response rates appear to be equivalent in high-risk patients with deletion 17p, fludarabine refractory, or unmutated IGHV. But unlike the kinase inhibitors, we see a much higher rate of complete response here. Again, even as a single agent, about a quarter of patients achieving a complete response on ABT-199. There does seem to be good durability to this as well. Remember that this is a phase 1 first-in-human study, so we can't really compare these PFS curves to phase 3 data that's more mature from ibrutinib and other compounds. But nonetheless, we haven't reached a median PFS yet in these patients treated at the recommended phase 2 dose of 400 milligrams or above. This appears to hold up as well in the high-risk patients, so there does seem to be durability to the single agent as well. So what about combinations? Well, the main data that we have so far for combinations of ABT-199 is with our old friend rituximab. Smaller data set here, about 50 patients, similar age, late 60s, male predominance, higher lymphocyte count in this study, and that's probably partially because the median number of prior therapies is less. So the first-in-human study had 4 prior therapies. Here it's a median of only 2 prior therapies, so a little bit of a less sick population in this study. But most had close to 5 centimeter at least lymph nodes, and about 20% of patients had deletion 17p, and most of the patients were refractory to either fludarabine or rituximab. The toxicity profile with the combination looks quite similar to the toxicity profile of ABT-199 as a single agent, perhaps slightly higher rates of neutropenia, as you might expect with rituximab, which can also be related to that. But again, low rates of febrile neutropenia, just 2 cases of Tumorlysis Syndrome, again, early on. Since then, there's been well over 100 patients treated with this drug, and there's been no additional tumor lysis with the new dose escalation scheme. And again, very striking efficacy data in all 3 compartments that we care about in CLL, not just lymph nodes like kinase inhibitors, but also in the absolute lymphocyte count, and strikingly, again, in the bone marrow with the majority of patients having complete bone marrow clearance with this combination. Aggregating the response data for this phase 1b study, see close to a 90% overall response rate and about a third of patients with a complete response. And that seems to hold up close to that, maybe a tick less with 17p patients, but certainly very impressive CR rates for very high-risk patients with 17p disease. MRD negativity is also being measured a bit more systematically in this study, and so far, MRD negativity in the bone marrow has been observed in 17 of the patients. Interestingly, you can see that's higher than the number of patients who have achieved a CR. So there's actually been several patients on this study who have had dramatic shrinkage of lymphadenopathy, with lymph nodes going from large conglomerates down to 1.7, 1.8 centimeters in maximum dimension. So those patients can't count as a CR, but they're actually achieving MRD negativity in the bone marrow as well. So that may even be more important in terms of their long-term progression-free survival. So why does all this matter, MRD negativity, CR? You've heard from the other speakers that maybe that's not relevant anymore in CLL. Well, I would contend that it is for a couple of different reasons, and one of them is illustrated here. And just to avoid confusion, venetoclax is the new generic name that is taking over for ABT-199, so it's the same thing. So in terms of patients on this phase 1b study, there's an interesting thing in the protocol where they actually allow patients to come off treatment. They stay on study, but they can't come off the venetoclax or ABT-199 by their own choice if they'd like. And 5 patients have opted to do this so far. 3 of them did this earlier on in the study, so focus in on those to start. So in the green here, you see these 3 patients who achieved CR within a few months of starting on the venetoclax with Rituxan combination. And then they elected to come off all treatment and just go back on observation. And you can see in the blue here that these patients have now been off of all therapy for longer than they were on the therapy, and they remain in complete remission. And so I think this has some distinct potential advantages. Number one, the economics of it. Not having patients on lifelong therapy is good at a societal level. But number two, for patients, I think there's still some uncertainty about, if you have a burden of disease around, whether it's a lymphocytosis or residual lymphadenopathy or even residual bone marrow disease, are these the patients who may later develop Richter's transformation or BTK mutations or other things that are going to make them resistant to drugs? So I think the idea of achieving a CR with a drug that is generally well tolerated, assuming that the precautions are taken for Tumorlysis Syndrome, of course, I think that's a very appealing option both on an economic and a biological perspective. So what's the best approach for a patient with multiply relapsed CLL? I'd say that the future is now. There's lots of exciting choices, and obviously combinations of these drugs are going to be very important in terms of future studies. But if you had to pin me down on maybe just one approach, kinase inhibitors or ABT-199, kind of, again, dangerous to compare across studies, but trying to compare across the earlier studies so that everything's as equal as possible. We see high overall response rates with all these drugs. We see significant improvements even as monotherapy in terms of complete response rates, and we see nice durability with all of these agents. And as was alluded to by our speaker, Dr. Chesson, in his earlier questioning, we do see some serious internal bleeding on occasion with ibrutinib. It's not frequent, but it can happen, and we see atrial fibrillation, so these long-term toxicities, particularly for our older patients, are not trivial. With idelalisib, we're all very familiar with the black box warning for colitis, pneumonitis, and hepatitis, which are real toxicities that we see with this drug. And with ABT-199, we have a nice dose escalation scheme now that obviates the tumor lysis risk that was seen before. And with, as I said, well over 100 patients treated on the new escalation scheme, there's been no clinical tumor lysis observed. And then once you're on the drug, the toxicities of it are quite minimal. So I'll let you make the choice, but I would certainly strongly advocate for ABT-199 as the first choice for multiply relapsed CLL after chemoimmunotherapy. Thank you.